let me just get the recording going. So today we're going to speak about handling tricky blood transfusion cases. And we have the team of SANBIS with us. These recordings are now available on Deep Dive. Please chat to the SANBIS team. They are 5 strong and has a lot of experience, well, the experience in this field. We can also discuss at the end, and for CPD points, you know, you have to fill in the survey at the end. And this is to thank us. And we got through this beginning. Thanks, Gardine and Melanie. And the agenda for today, which I will also obviously leave to Ute to discuss, is I will leave it to her, but I'm going to introduce her. So Dr. Ute Jens is a medical microbiologist, and she's been working in a lot of very important trial labs at WITS in the HIV testing and the early epidemic. And she is now in the immunohematology reference lab. She is heading that up. And I know her from working together with her in the Fogarty grant that we are doing in a collaboration between University of San Francisco, SANBIS, and Cape Town University. And Ute's vision has become the present, not even the future, because these genetic platforms are really with us. And I hope we hear a bit more about that today, how to really do diagnostic work in the best way. And she is a family person and has warmly entertained and invited the teams at her home before. I've been privileged to be there. And the presenters, I'm going to leave that to you, Ute. Over to you. Very welcome to these 5 very skilled experts from SANBIS at Deep Dive today.
Thank you very much, Estelle, and thank you very much for joining this deep dive session this afternoon. I'm really encouraged to see so many people, and we really feel honored from SANBIS and from specialized laboratory services and specialized therapeutic services to entertain you today. And maybe just to give you a high-level view, we really will start with the reagents that are used to test patient or donor samples. Many of those are made in our laboratory called the reagents laboratory. That will be the talk given by Luandri. So it's quite technical. It has to do with production. These reagents go to blood banks and also to some private laboratories. And then we're going through to our reference laboratory in immunohematology, in which Nitesh works. So this is, just to give you an idea, preliminary testing, cross-matching, and finding suitable blood for our patients. The hospital is done at blood bank level. However, any queries, any difficult cases, any complicated antibody cases are referred to our laboratories. The second level are the red cell serology labs, and from there to the reference laboratory. And this is where Nitesh works. And Debbie McLinden is the overall overseer of the immunohematology laboratories. She herself is the manager, but also a subject matter expert in this field. So these 3 colleagues who will present to you collectively have about probably more than 60 years of experience in the blood service. So Debbie spent all her life there, and Nitesh and Luandri also have spent more than 10 years in immunohematology. So I think you have a technically very solid team. Also beyond this call, if you have any queries, you're welcome to contact us. And I will give you a little bit of background to each of them before we start. And then our final lecture will be from Dr. Tanya Glatt. She is a hematologist working in the specialized therapeutic services. Good. So let's start off with with our speakers. So Luandri will be first, as I said. So she does the production, the bottling, capping, dispensing of all the reagents. She has a diploma in biomedical technology, and as I've mentioned, has been with reagents for over 10 years. So that's Luandri. Good. So we're doing the talk first and then the next speaker, Estelle.
I'm happy if you want to introduce them all and we just...
Okay, let me do that and then we can flow better.
Let's do that.
Yeah. Okay. Yeah, the next person I will introduce, we're coming to the bio just now, is Nitesh. As I've mentioned, he works in the reference laboratory. He's also been with SANBIS for about 10 years. And he brings with himself also a very research-orientated skills and interests. He's currently busy with his master's, looking at blood group distribution in the South African population. So that will be published shortly. But he's also the subject matter expert in this field, and he sort of has bridged very easily the science of serology going through into molecular testing. So that's Nitesh, and Nitesh is also linked to Fogarty. And then Debbie, yeah, so Debbie has really lots and lots of years of experience in immunohematology. I think she's worked in every immunohematology lab at SANBIS and currently heads up all the laboratories, which are both in Johannesburg and in KZN. She's also a member of the ISBT Rare Donor Working Party. And really, in addition to being a manager, she's really also in her own right a subject matter expert in the technical aspects of transfusion medicine. And then our last speaker, so this is Tanya Glatt. She is a hemopathologist and has been working at SANBIS, I think, Tanya, probably now about 3-4 years. She's the lead consultant of the Specialized Therapeutic Services and also the JC Hematopoietic Stem Cell Processing Director, and her laboratory has just been recently successfully inspected. So her interest, she combines hematology with transfusion, hematopoietic stem cell processing, and obviously this leads into her also supporting our laboratories in immunohematology. Great, we are ready to go. So thank you very much to the speakers. Speakers and listeners can relax and enjoy this journey. I think what we should do is, Estelle, what do you think? Do you want to break after each talk or should we go through?
It really depends on how you would want it.
Okay.
I think if there's clear questions on in the chat box that you think would be nice to discuss at that moment with the speaker, then you do it then. If you say, no, I'd rather let that question stand over until the end, then, and that's, yeah. So I think that's what we always do and it works well. So it will be your choice. Okay.
Yeah, good. I think the high level, what I'll do, I'll let the 3 lab talks happen, and then we'll maybe have a bit of a transition before we go to Tanya.
Okay, that sounds great. Okay, perfect.
Good. Okay, thank you. Good, Luandri, you may start.
Luandri, can you unmute? I can't hear you. Oh. I'm not quite sure why I can't
No.
hear you. Is it just me or?
No, I think we have a sound issue with Luandri. Don't stress, just relax. There's some problem there. Luandri, we can't hear you.
Yeah.
Uta, would you like me to continue with my talk while Luandri sorts out hers? Yeah, maybe. What do you think, you or Nitesh? It's up to you. I'm ready to go. Okay. Okay, Debbie, I think you go. I don't want to waste any more time. So let you go.
Thank you, Debbie.
Okay. All right, super, not a problem. Can you confirm if you can see my screen?
Yes.
Yes. Great, super, thank you. Then let me launch right in. Thank you very much for the invitation to present today, and thank you for the introduction. I certainly feel old, but I'm really very privileged to share with you a little bit about the laboratory management side of managing red cell alloimmunization in sickle cell disease. So I hope you can see clearly. I'm sorry, because of my view, I'm unable to put it in presentation mode.
Looks great.
But as long as you can see it,
Perfect.
then I'm happy. Great, thank you. All right, so maybe it's fine if I go first, because my two of my team members, Nitesh and Luandri, really fall very nicely into this organogram here. And I thought I must just share where we sit in terms of the services that we offer in our department before I go on to the alloimmunization side of it as well. So I'm the immunohematology manager, and I have the privilege of managing our two red cell serology laboratories in Constantia-Kloof and Mount Edgecombe, as well as the reference laboratory and the reagents laboratory here in Mount Edgecombe as well. And I'm very ably assisted by a quality and admin officer. So we are accredited laboratories. We have an ISO 15189 accreditation. And in addition, our reagents laboratory is SAPRA registered, and we are working towards an ISO 13485 certification as part of the new SAPRA registration that we are working towards. So Luandri will really talk to you about the production side. But I couldn't touch on the immunohematology labs without mentioning the reagents laboratory and the work that they do, because they are involved extensively in reagent production. And a lot of this is red cell reagent production, which is really an art form, as Luandri will share with you when she speaks shortly. So we produce, test, bottle, and we also distribute various testing reagents, both to SANBIS internal laboratories and to external customers as well. Then a very key part of our department, the reference laboratory, we are involved in the South African Rare Donor Program, and in fact, we are the custodians of this program. So we're involved in the storage and thawing of rare donations. We also provide rare blood, both locally and internationally if required. We have a family studies program where we try and identify rare family members of rare patients. And then we manage those rare donors. We try and encourage them to keep on donating, and we manage their donations to make sure that we don't lose them. The reference laboratory also performs a lot of testing and confirmatory support to the reagents laboratory, but also to the red cell serology laboratories. And the reference lab runs a 24-hour on-call system for blood bank and red cell serology problem case support. So that is to ensure that our patients who need blood can receive blood, even if it's a problem case, 24/7. Our red cell serology laboratories are really our primary investigation laboratories, and they perform all the investigative work around problem cross matches. So your initial antibody investigation and the provision of compatible units for those cases will initially go to red cell serology. They also have a 24-hour on-call support system for urgent cases.
They have some external work as well. So they do some antenatal testing, and they also do a lot of confirmatory work for internal SANBIS laboratories. Then key, they are involved in transfusion reaction investigations and various other testing and phenotyping for external customers. All right, so getting on to sickle cell patients specifically, I can share with you our recommended baseline testing. And because these cases are really referred to the immunohematology laboratories, we're trying to encourage a kind of standardization of our approach in the way that we manage these patients, certainly from a laboratory point of view. And we recommend that before patients are transfused, really this is wherever possible, we would like to do a baseline ABO and RHD type and an irregular antibody screen test. So we want to see if there are red cell antibodies present, and this would be great if we can do this before this patient ever receives blood. If there are antibodies present, in other words, if it's a positive antibody screen, then we will want to identify those antibodies so that we know what we're working with before the patient needs blood. A direct antiglobulin test will be very helpful, and Nitesh will go a little bit into detail about that. We'll do an autoantibody test, and then we would want to do an RH and K phenotype so that we can give RH and K phenotype matched blood to the patient. And then we can do any extended phenotyping that you'd like. So that would be on request and as required. So why would we want to perform baseline testing? And there are just a couple of benefits that I thought of off the top of my head. I'm sure if I spent more time, I could think of more. But the first one that comes to mind is that then we have a known patient profile and a record here at SANBIS, which helps us to provide blood quicker. That's the simple point here. So it will assist us with laboratory monitoring and also to make sure that if there are any changes in an antibody profile, we would be able to compare that to the initial testing. If we have a matched or a phenotype patient and we're giving matched blood, we can minimize the risk of alloimmunization of that patient. Of course, I'm referring only to minimizing risk where we are matching for specific antigens. So we can't guarantee that there'll be no antibodies formed to other antigens present. Very importantly, if we do baseline testing, we will have an early identification of any rare types. So this happens from time to time when a patient needs blood urgently, and suddenly we discover this patient is of a rare type, and we first need to identify the rare type, and this can take some days before we even go on to identifying if we can provide the blood or not. Another advantage is to, ahead of time and as far as possible, prepare the phenotype matched blood prior to transfusion. This, of course, will not be for emergency cases. And then to provide phenotype matched blood to sickle cell patients is in line with international standards. And a lot of people and a lot of services and medical centers are now managing their sickle cell patients this way. So of course, there always are some limitations that we need to be aware of. And the first one is the availability of blood. And I think that's a key one for any blood service. So if we're looking for a specific phenotype, if it's not available, that will be a delay in the issue of that blood. And then, of course, this is not a suitable system for issuing of blood in emergency cases. So I don't expect you to see this in any great detail, but this is our immunohematology request form. So it's just for your information, and we'd be prepared, we'd be very happy, in fact, to share the form with you if you need any further and additional testing by any of our immunohematology laboratories. Just give us a shout and we'll be happy to share the request form with you. So from a laboratory perspective, I really want to share with you some reasons for delays in the issuing of blood. And this is really key for anybody who's ordering blood for a patient. There are cases where you won't get your blood as quickly as you'd like. And some of these reasons include complications in lab testing. So if we have patients who've been recently transfused, that can cause issues in the cross-match test, as well as patients whose red blood cells are sensitized. patients with autoantibodies and or multiple antibodies or antibodies against high-frequency antigens. These all cause complications in laboratory testing and will certainly result in a delay in the completion of the cross-match and the resolution of that case. And then there are complications in the provision of the blood itself. And some of them are really basic. Incomplete documentation that we receive in our labs or in our blood banks can definitely lead to a delay in the issuing of that blood. Insufficient patient sample is also a big one. And that is something that we experience quite often in our immunohematology labs, where we receive a specimen that has already been through the blood banking process, and then we don't have enough sample to complete our testing. So that will definitely lead to a bit of a delay. The presence of red cell antibodies. So obviously where you need to source antigen negative blood, that can lead to a delay depending on what antigen negative blood exactly you are looking for, but it's something to bear in mind. Any cases where there is additional testing, so anything additional to a standard compatibility test or cross-match may result in the delay in the provision of that blood. And then very, very importantly, provision of blood from the rare donor registry will most certainly result in a delay because these units are stored frozen and they have to be specially ordered. They are then put through a deglycerolization process and they have to be shipped from our repository in Mount Edgecombe. So any blood which is required from the rare donor registry needs to be planned very carefully and will take some time to get to the patient. And then, as I mentioned before, the provision of phenotype blood itself may lead to a delay depending on what phenotype you're actually looking for. So we'd be happy to share these details afterwards. If you would have the need to contact any of us, please feel free. Our contact numbers are on the screen. And any of us will be able to assist you with any of your queries.
Okay. Thank you very much, Debbie, for your presentation. As I've mentioned, I won't take questions now, but I just want to point out a comment from Andrew MacDonald, because this is important. He says, for our red blood cell exchange hypertransfusion program, we are doing extended phenotyping requests at SANBIS. As noted, emergency setting is more of a challenge. So that is really great, and especially in these multiply transfused patients, you know, the ones that are not managed carefully or tight before, we do see extensive antibody development. So this is a good practice. And although the emergency setting may be more challenging, at least we, in these cases, have something on record at SANBIS and will guide, you know, looking for suitable units. So thank you for that. Good. I would now like to hand over to Luandri. Let's just check if she is ready.
Dr. Uta, can you hear me now?
Perfect. Wonderful. I can hear you very well.
Okay, so let's try this again.
Okay, you go.
Okay, so good afternoon, everyone. My name is Luandri Visa, and I'm the supervisor of the reagents laboratory at the South African National Blood Service. Today, I would like to share with you how we select and produce the screen and panel cell donors to create the perfect decode. We manufacture test cells every 4 to 5 weeks. This is equal to a volume of 75 liters of red cell suspensions. The test cells include grouping and screening cells. After 75 liters, 3,800 vials are dispensed and the remainder is kept as bulk stock. The shelf life is 46 days. We also prepare around 60 sets of panel cells every 2 weeks. The shelf life is 21 days. The reagents manufactured in this laboratory is distributed to internal and external customers across South Africa, as well as to some of our neighboring countries. Okay, so the screen cells are used to detect the presence of irregular red cell antibodies and will yield a positive or a negative result. The panel cells are used to identify the red cell antibodies present in the sample. Our decode criteria is based on the following UK guidelines. The cells must be from confirmed Group O donors. the following antigens must be expressed: big C, little c, D, big E, little e, K, little k, FYA, FYB, JKA, JKB, S, and little s. Donors with known low-frequency antigens must be excluded. The set must be prepared from 2 different donors, and the cells may not be pooled. The one RH must be R2R2. What this means is the donor is D, big E and little c positive, but big C and little e negative, as you can see in my little table on the side. The other donor must be R1R1, and this means that they are D, big C and little e positive, and negative for big E and little c. You should use cells homozygous for D, E, Duffy, and the KIT antigens as far as possible. Donor matching is done in such a way to ensure maximum coverage of all the antigens to clinically significant antibodies. Sanbus has decided that the screen 2 will always be K positive. Definition time. A donor is assumed to be homozygous for antigen when they express only one of the 2 antigens. An example of this is when a person is big C positive and little c negative. The person is said to be homozygous for the C antigen. Heterozygous is for antigen C, is where the person is positive for both the C and the little c antigen. In our screen pair matching, it is done by looking at a fully phenotyped Group O donor list. In this example, I am showing you 10 of our fully phenotyped K positive donors. We always start with the screen 2 or the K positive donor because most people are negative for the K antigen, and this is harder to find. We would check on our computer system to identify if any of these donors are due to donate. From the original 10 K positive donors, only on the previous slide, only 1 is due to donate. I have removed the other donors from our checklist and kept only the donor number 3 on this list. Donor 3 is R1R1, as you can see there. So the match has to be a R2R2 to cover the big E and little c antigen that the donor 3 lack. Consult the K negative donor list and select R2R2 donors as possible matches. What we see in the table at the bottom of the slide is 8 RH matches. From here, we would identify all the antigens negative in donor 3. Donor 3 is negative for little s and LEB. So donor 16, as you can see there, is also little s negative and would not be suitable as a match. Donor 11, 12, 13, and 14 is LEB negative and would also have to be removed from this list. All clinically significant antigens has to be covered between the 2 screen donors. So finding the one, the matches must be positive for the antigen negative in donor 3, like I said to you before. Here we have the little s and there we have the LEB. So the donor matches below it has to be positive for them to be a match. With this example, the screen 2 donor 3, has 3 possible matches, number 15, 17, and 18. All the clinically significant antigens are covered between these 2 donors. Okay, now that you have a basic understanding of the screen cell decode, I want to move over to the panel cell decode. Listed below is the UK guidelines again. All donors must be confirmed as Group O. The cells must be tested against antibodies for C, CW, little c, D, big E, little e, K, little k, FYA, FYB, JKA, JKB, S, little s, LEA, LEB, M, N, and P1, as well as LUA. The panel cells must comprise of 9 or more donor cells. The panels must have a distinct pattern of reactivity to all the commonly found alloantibodies. To create the perfect pattern, as with the screen cell donors, you would consult the list of fully phenotyped Group O donors. The reaction pattern for the following is always the same. I've highlighted them in yellow. Panel 1 is D, big C and little e positive. Panel 2 is big C, little c and little e positive. Panel 3 is big E, big C and little e positive. Panel 4 is little c, little e and K positive. Panel 5 is big D, big E and little c positive. Panel 6 is D, big C and little e positive, and is also the only panel that is positive for CW. Panel 7 and 8 is C and little e positive. Panel 9 is D, big C, little e, and K positive. Building the team. Next, you would check the donor list to identify which of your donors recently donated or who is due to donate. To slot them into the panel. Check that there is a unique pattern for each antigen. It might be necessary to request a specific donor to be bled to be able to create the unique pattern on this decode. Check that no antigen has the same reaction pattern as the RH antigens. The panel cell decode is read from the left to the right to identify the antigen patterns. I have highlighted the positives for our RH antigens in red. The D antigen is positive in panel 1, 5, 6, and 9. The C antigen is positive in panel 1, 2, 6, and 9. The CW is only positive in panel 6. The big E antigen is positive in panel 3 and 5. The little c antigen is positive in 3, 4, 5, 7, and 8. The little e antigen is positive in all the panels except in panel 5. The K antigen is positive in panel 4 and panel 9. On this slide, I have highlighted the positives in orange of the other antigens. The constants are in red, so by using color, it makes it easier to identify the reaction patterns to ensure uniqueness. I have highlighted the 1CW in panel 6 in the color teal. And please note that we have one KPA positive, but that is found in panel 7. So this is acceptable because it's not in the same panel. If we had to have that KPA positive in panel 6, we would have had to add another KPA to this panel. All the reaction patterns in this panel is unique and is thus acceptable. Okay, so now I would like to take you through a simple example on how the decodes must be used. A blood sample was tested against screening cells, and the screen 1 cell was found to be positive by IAT. So what we would do is we would highlight all the antigens positive in screen 1, but negative in screen 2 on the screen cell decode. So on this slide, I have the screen cell decode for you, and that's exactly what I've done. I've highlighted the antigens that's positive in only the screen 1, but negative in the screen 2. So the antigens that was identified is big E, little c, S, JKA, LEB, and FYA. The antibody present in this sample could be towards any of these antigens identified. To determine the specificity of the antibody, test the sample against the 9-panel donor set. Okay, so this was the antibodies, the antigens that we identified. Okay, so after testing the sample against the 9-donor panel, a new reaction pattern is created. Panel 1, 2, 3, 5, 6, 8, and 9 is positive. And it means that donors carry the corresponding antigen to the antibody in the sample. So now let's look at our donor decode. Okay, so for your reference, I've included the panel cell reaction pattern at the top of the screen. Firstly, I will highlight the antigens identified in the screen decode in red on my panel. This was big E, little c, S, LEB, FYA, and JKA. Then we had a positive in panel 1. So I would go and mark those antigens positive in panel 1, but only look at the ones where I highlighted the red in red. And what I can identify here is that LEB, FYA, and JKA is positive in panel 1. Okay, so from this slide on, I have blackened the side of the decode to the antigens which does not correspond to the sample results which we have at the top. Okay, so here we have panel 2 that was also positive. So go mark the antigens positive and in panel 2 next to the teal positives we had in the previous one. Again, the antigens positive is an LEB, FYA, and JKA. Panel 3 was also positive. We will do the same and mark all the antigens positive in panel 3 against next to the pink that we had before, and the antigens were positive and LEB, FYA, and JKA. Okay, so panel 4 was negative, and now we're going to do the same. We're going to mark the negatives next to the yellow we had before, and here we only have it in LEB and FYA. So for panel 5, we had a positive as well. We would do the same and mark the panel 5 positives, which we've done there. So now we're only left with FYA. So the next one, we looked at panel 6, which we had a positive. We would go look, yes, we have our positive there, and we would mark it. So we're still left with FYA. So panel 7 was negative. We go look at our decode. Yes, the negative matches. So we're still on track with the FYA. The next one, I've just combined the two. Panel 8 and 9 was positive. So I marked the panel 8 and 9 on my decode. Okay, so here's our very last sample. I just wanted to show you. Here we have the perfect pattern for FYA. We only have one antibody in this sample, and it matches our decode perfectly. Thank you for your time.
Okay, thank you very much, Luandri. I'm sure you can all appreciate how much work this is. And I think we have a comment somewhere here. Philip Sneyman is asking you, Luandri, don't you have a computer software that can do this elimination automatically? This is very responsible work you're doing. I'm sure we can at least appreciate that, it's not just about bottling reagents. This is about accurate identification of specific patient antibodies. But maybe you want to comment. Have we looked at something automated or semi-automated for this?
Dr. Uta, we have not looked at it before, but I think once we have the new BEC system, it will definitely make this whole process easier.
Yeah, thank you. Yeah, so Philip, just back to you. For our immunohematology labs, we are probably now in year 5 in trying to automate more and more of all the manual processes. And we've done quite well with interfacing instruments, but there are still gaps. And you're quite right. This is something that you want to automate also to reduce the risk of error, although we have very strict quality control guidelines. Good. Okay, let's move on to Nitesh. Nitesh, you can start with your presentation. Thank you.
I will now. Okay, can everybody see my screen?
Yes.
Okay, so hello everybody. Well, it's now 4:45, so let's see how quick I can go through this. I'm going to put this into presentation more quickly. Okay, so my name is Nitesh Jagannath. I'm actually the subject matter expert for immunohematology. I work with the red cell serology laboratories as well as the reference laboratory that is based in KZN. So just a short introduction into these IMH laboratories. So problem cases are referred to the red cell serology laboratories from within SAMBUS. These are the 84 blood banks that SAMBUS actually operates, and they are referred to either the red cell serology laboratory in Constantia Kloof or the laboratory that's based in KZN. Where these cases now cannot be confirmed by either of these two identification laboratories, the samples are then sent to the reference laboratory, which is based in KZN. Now, the SAMBUS reference laboratory performs advanced serological testing, and we also perform molecular testing. We are the endpoint testing for South Africa, so we do perform the confirmation testing for Western Cape Blood Services as well. Now, due to the specialization of these tests, each case is unique and therefore requires a selection of tests to be completed according to the testing options available in these IMH toolboxes. So just a quick overview of what's in these toolboxes. The red cell serology laboratory is able to do antibody identification. They would do a titration to determine the titer of the antibody, and then they can do red cell phenotyping, which is actually quite exciting. The tests available in the reference laboratory toolbox. So the reference laboratory will also do antibody identifications, and this is using the saline method, which is the tube method, as well as enhanced testing using column agglutination. Titrations are performed to determine specificities of antibodies, and also if there are multiple antibodies, we would be able to determine the titer of each antibody in order for us best to advise treatment. Red cell phenotyping once more is performed in this laboratory, but the reference laboratory is actually quite special because they're able to do the typing for the rare phenotypes because they do store rare antisera. Molecular testing is performed, and this is on two separate platforms. One is a multiplex that is actually able to cover 10 blood group systems and 37 different antigen types, and we will cover this later. And the second molecular platform is actually a STAT test that covers 13 blood group systems. And although it's not able to cover all of the different antigen types in these blood group systems. The reference laboratory also does a specialized test called the MIGHTY monocyte monolayer assay, which is able to determine the reactivity in a patient to a degree. So just a quick overview of grading. So as you can see up here, this is what we would call a 4+. So it's a very strong agglutination where there's a single clot. And then it would go down from there to a 3+, where you can see there's actually two separate agglutinations, to a 2+, a 1+. This is a hemolysis reaction. So it's actually a very strong reaction where the red cells were actually destroyed. And the last reaction here is the negative reaction, where there was no reaction between antigen and the antibody. So with regards to ABO blood grouping, we would actually type for an anti-A, an anti-B, an anti-A, B using the patient's red cells. And then the A1, we would use A1 cells, A2 cells, B cells, and O cells to type for the corresponding antibody to the antigen that was found. In most cases, we would also type for, or in cases where it's a group A, we would also type for the anti-A1 to determine if the patient is an A1 or an A2. So I've got the basic groupings actually marked in green. So you can see for the anti-A, you'd see a positive with this reaction for a group A patient, a positive with the anti-A, B, a negative against the A1 cells and the A2 cells, a positive using the B cells, and a negative using the O cells. For a group B, you'd find the anti-A being negative, the anti-B being positive, the A, B actually being positive, the A1 cells and A2 cells also showing a reaction, and the B cells and O cells showing no reaction or being negative. For a group O, you'd find a negative reaction or no reaction in the forward grouping, which means the anti-A, anti-B, and anti-A, B. And you'd find the A1 cells would be positive, the A2 cells would be positive, and the B cells being positive. For the AB, or in this case specifically the A1B, you'd find a reaction in the anti-A, anti-B, and anti-A, B, with no reaction being found in the reverse grouping, or the A1 cells, A2 cells, B cells, and the O cells would all be negative. With regards to Rh blood grouping, this is the tests that are performed in reference laboratories specifically. You'd find a positive reaction with the anti-D that is used, and a negative reaction for Rh negative samples with the anti-D that's being used. The reference laboratory would therefore also grade reactions based on the reaction, based on the type of reaction. So where it is a 2, we grade it as a high grade weak D, a 1 being an intermediate weak D, and if there's a microscopic reaction or a very weak reaction, we'd call it a weak grade weak D. So now that we've done a bit of the agglutinations and patterns that we want to find, let's do 3 samples. So workshop sample 1 is a sample that's taken for a patient A. So this patient had been pregnant previously, and this is actually her second pregnancy. So she was advised by her doctor, who seems to have been a very smart chap, to have antenatal testing performed, because he noticed that her blood type was actually group A, and more importantly, Rh negative at this point. So the testing performed in the red cell serology laboratories, when the sample is received, when the sample is sent, it is received in the red cell serology laboratory, and the first test that is performed is a screening test to determine if there are any irregular antibodies. Lowandri did cover this, that the screen cell 1 and the screen cell 2 would cover all of the antigen types. So it's able to tell you if there's an irregular antibody there, although it is not able to tell you the specificity of the antibody. So both screens positive, indicating the presence of an irregular antibody. The antibody identification test was then performed using our routine panel cells. So we would use the entire panel. So it's a panel 1 to 9. We'd also do an AA and an AB. Now, an AA is an auto antibody test. So we would be able to check if the patient has an antibody to their own cells. So that is the auto antibody. The AB, or rather, we would also call that a DAT test, is to determine if the patient's cells are sensitized. Should this have been positive, we would have taken this further to determine the type of sensitization. But this is negative, so we would not go further with that test. So then we did an antibody identification. We found that the patient against the first panel was positive, second panel was negative, third panel is negative, fourth panel is negative, the fifth panel is positive, the sixth panel is positive, the seventh panel is negative, the eighth panel is negative, and the ninth panel is positive. So the way the test is read are these are all of the different antigens that are present in this panel decode. And this is the reaction pattern. So we would look for a reaction pattern in these antigen types that would match the test. Can I give you 10 seconds to actually do this? Oof, I stopped sharing. Let me start sharing again. Everybody? Okay. So this reaction pattern, when we compared it, we would say it's a anti-D, simply because the reaction pattern matches exactly to what is found in this patient. So we would conclude this, therefore, as an anti-D in this patient, which is significant as the mother is Rh negative. So workshop sample 2, a slight background. This was a sample from patient B who was received in the blood bank. The ABO and RH blood typing was performed in the blood bank. Now, this is regularly performed in the blood bank to determine the selection of blood. When the screening was performed, they noticed something a bit irregular. The screen cell 1 was positive and the screen cell 2 was negative. So there was a irregular antibody present here. So compatibility testing found all of the units to be incompatible. And we would go further with those to determine if we can find what is the antibody here. So the sample would be forwarded to the red cell serology laboratory for the identification test. The sample is then received from the blood bank and the identification is performed once again using the 9 panels. Simplify this out a little bit. We would once more try to determine what is the reaction pattern for this. As can be seen here with our test result, this is very different to the first reaction pattern where we had panel 1, 5, 6, and 9 only being positive. Here we've got all of the panels except panel 5 being positive. So then we would look for a suitable reaction pattern. I'll give you 10 seconds. Okay, so when we look through this reaction pattern, we would find that it's an anti-E, or more specifically an anti-little e. As you can see, it is positive in all of the panels except for panel 5. So this is the antibody that we would determine that is present as the irregular antibody. Ah, my favorites. So workshop sample 3, I've decided to use a rare case. So the sample from patient 3 was received in the blood bank. Once more, an ABO and RH was performed. However, when screening was performed for this patient, it was found that the screen cell 1 and the screen cell 2 was positive. All of the units that were tested were found to be incompatible. The sample was then sent to the red cell serology laboratory for an antibody identification test. So when the sample was received at the red cell serology lab, they immediately performed the antibody identification to determine what would the antibody be. This was their result, where all of the panels actually now came up positive. So when we look at this panel or this result pattern together with the panel, we can see now there is a lot of antibodies that could be positive here, that could be possible for this patient. If we're looking specifically for the reaction pattern, we can see it could match an LUB, which is a rare type, or it could match the little k, which is also a rare type. However, looking further, this could also be multiple antibodies. So the reaction pattern of more than one antibody giving us the entire panel being positive. So that's how would not be able to conclude this antibody based on these preliminary results. They would thereafter refer the sample to the reference laboratory. So as I explained previously, the reference laboratory is able to perform advanced serological testing. One of the things that Debbie did explain was that the reference laboratory are the custodians for the rare donor file. So we do keep cells that are negative for high frequency antigens. So we would type the patient's plasma or serum against our rare panel. So this is an example of a rare panel. So you've got an HRS negative or an RH minus 18, an HRB negative or an RH minus 34, a little k negative, a KPB negative, a JSB negative, a U negative, a LUB negative, a DOB negative, and a VAL negative. So each one of these is a rare type. When we would have typed this, we found that this HRB was actually negative here. So this indicates that this would be the rare type. We would then take that further into molecular testing. Now, molecular testing is performed, as I said, on 2 different systems. The most conclusive system for us to actually identify the Rh system HRB negative will be our multiplex system. Once more, it tests 10 blood group systems and 37 different antigen types. As can be seen here, the HRB was found to be negative on this test. So that would confirm the testing performed using serology. So the molecular testing concluded the absence of the HRB gene. The absence of this gene would then infer that the corresponding antigen would actually be lacking. So this is a high frequency antigen, therefore it is a rare type. It would confirm the serological results, and we would then make recommendations to the patient's treating doctor that we would need to thaw units, source units from our rare donor file, and the patient is to continue to receive these rare units. I think I've got 2 minutes more. Okay. Just to share quickly here now. Let me put this presentation mode once more. Just to share quickly here, I've highlighted all of the different rare types done on this multiplex system. And as you can see, it's able to type from HRS, HRB, little k, KPB, JSB, the DOMBROC, the HY, JOA, YTA, and LUB, all in a single multiplex test, which is quite nice because we can run one test for multiple rare types. And thank you. I think that was 20 minutes for me.
Okay, thank you very much, Nitesh, for your presentation. I will just ask you to answer one question before we go to Tanya, just because it refers to what you talked about, testing in pregnancy. If a pregnant patient has a positive indirect Coombs test but is Rh positive, do you suggest identifying which antibody she has?
Yes, if the patient is pregnant and does have a positive Coombs test, there are other antibodies that are able to cross the placental barrier that could actually be affecting the baby. Some antibodies, should I say, are very hard to detect. For example, if the patient has a anti-big K that has crossed the placental barrier, anti-big K does cause HDFN. However, you won't see that in the mom sample because it also inhibits erythropoiesis. So that is where we would actually suggest, if there is a test that is positive, especially a Coombs test, we would suggest the antibody identification of the mom to determine if there's another antibody that could be sensitizing here.
Okay, good, thank you. So just for the audience, I know there are more questions to the team, but I will leave those to the end. I just want to give Tanya a chance to give a presentation, and then we'll come back to all your questions. Tanya, are you ready?
I hope you can hear me and that you can see my slides. So I'm going to be speaking about 2 things: continuing alloimmunization in sickle cell disease, as well as therapeutic monoclonal antibodies and how those affect us in blood transfusion. So in sickle cell disease, we know that red blood cell transfusions are very common. 90% of adults have received at least 1 transfusion, and some patients receive over 100 transfusions in their lifetime. And red cell alloantibodies are also very common in sickle cell disease. So the literature is very, the range is very wide. Between 15 and 75% of sickle cell patients form red cell alloantibodies. And even when you adjust this for transfusion burden, so if you compare them to other chronically transfused populations like thalassemia and MDS, sickle cell patients really have more alloantibodies. And in addition, we don't necessarily pick up all of these alloantibodies because we don't routinely test a patient post-transfusion for an alloantibody. So, and these antibodies can actually evanescent and we may not pick them up. So if you transfuse a patient and they make an alloantibody, and then the next time you transfuse them is over a year, over a year's time, and you send us their blood, we won't be able to actually detect most of those alloantibodies. So this is a problem because we may be, a unit may look compatible, but actually result in delayed hemolytic transfusion reaction. So alloimmunization is common in sickle cell disease for a few reasons. Firstly, their high lifetime transfusion burden. Then there are also genetic factors between the donor and the patient. There's some sickle cell disease specific factors like the chronic inflammatory state and the chronic hemolysis, and even some genetic factors like Fc gamma receptor polymorphisms. Why are we worried about alloimmunization? The big reason is for delayed hemolytic transfusion reaction, which can be mild, but can be significant and even fatal. Women who are going to fall pregnant, delayed hemolytic disease of the fetus or the newborn. The other problem is that when you need blood for your patient in emergency and they've got alloantibodies, it's going to be delayed, especially if you want to red cell exchange them and you need very many units. And then these patients who develop allo antibodies to red cells can also develop HLA allo antibodies, which is a problem if you ever want to transplant them in the future. And they can also develop auto antibodies and present like an autoimmune hemolytic anemia. But the pathogenesis, there's a multifactorial pathogenesis of allo antibody formation, because not every patient who's exposed to an antigen that they lack will make an antibody. So this slide shows what happens in delayed hemolytic transfusion reactions. They get exposed to an antigen that they lack. They make an antibody. They make antibodies. These antibodies wane. Then you want to transfuse them again. We cross-match a sample. It looks compatible, but really the antibody is there. So there's, after the secondary exposure, there's this massive amnestic response, usually 3 to 14 days after the transfusion. The problem with delayed hemolytic transfusion reactions is that they really under-recognize. One of studies showed that with sickle cell patients who were admitted and finally diagnosed with a delayed hemolytic transfusion reaction, 92% of them were initially misdiagnosed. And there's a subset of patients that that not only destroy donor red cells, but also their own red cells, called bystander hemolysis or hyperhemolysis, which is very difficult to manage. And the sickle cell milieu is the red blood cell membrane integrity can be disrupted, and then there's increased phosphatidylserine exposure, and this can destroy the red cell membrane integrity, and sensitized red cells have an increased susceptibility to hemolysis. The problem is it's a vicious cycle, because these patients can then, this can then exacerbate their sickle cell disease symptoms. But you really have to, it's frequently missed, because these patients come in and their symptoms look exactly like a vaso-occlusive process. They have pain, fever, anemia, tachycardia, and unless you suspect it, you're unlikely to think of it. So in anyone who presents like this after a recent transfusion, you should consider the possibility of a delayed hemolytic transfusion reaction. The problem with them developing autoantibodies is that it complicates things in the blood bank even more. We can't find compatible blood, and then if they have underlying alloantibodies as well, it makes it difficult to identify these. And autoantibody formation is more common in all alloimmunized patients, but specifically in sickle cell disease with an incidence of up to 10%. Okay, so what are the genetic factors that contribute to alloimmunization in sickle cell disease? The first one is the racial antigenic differences. So our sickle cell patients are predominantly Black and our donors are predominantly white. And if you compare this to chronically transfused patients with more homogeneous donor recipient groups, you'll see that their alloimmunization rate is much lower. So in thalassemia, the literature says up to about 10%. And studies of sickle cell patients in Uganda and Jamaica, where their donors they have more Black donors, that their rates of alloimmunization are about less than 6%. So the first level of antigenic complexity is the fact that if there's going to be a difference in high frequency and immunogenic antigens, then the rate of alloimmunization is going to be higher. So the most common Rh phenotype that we see in sickle cell patients is they're big D positive, but they're big C and big E negative. And this combination is actually found in less than 2% of white patients. So so white people are often big C positive, big E positive, and Cal positive. And 2/3 of alloantibodies are actually made to these 3 antigens, big C, big E, and big K. So if you match for these three antigens only, you'll markedly reduce rates of alloimmunization in all chronically transfused patients, but specifically in sickle cell patients because they're more likely to form alloantibodies. And it should be the standard of care. It's the standard of care in most Western countries. The problem with this is inventory. So if you want to match for E, C, and K, you have to have phenotypically matched donors. And in South Africa, that's a problem because we don't have enough Black donors. Then usually in our white donors, if they are big C and big E negative, they're usually big D negative as well. And these are units, these are less than 15% of our units, and we want to keep those for Rh negative patients. So it does become difficult. And also in these donors, they sometimes have other antigens which are high frequency and immunogenic. And then your sickle cell patient will be could make an allo antibody to, for example, FYA or JKB. So that's the first level of antigenic complexity. But even if you match for those 3, there are still patients who develop alloantibodies. And that's because of the Rh variants that we see in our African population. So most sickle cell patients have 1 or more Rh variant. They can have a partial variant, which actually an epitope is missing. So we need to treat those as Rh negative, or a weak antigen variant where they just have a quantitative reduction in antigens. So in order to detect an Rh variant, you cannot pick this up by serology. You have to do molecular testing. It can also cause a problem because African donors can also have Rh variants, and then you can have your sickle cell patients making antibodies. So there's a case of a patient who's actually D positive, made an anti-D and looked like an auto-antibody, but was actually an alloantibody to an Rh variant. Okay, so there are also immune factors that contribute to the increased risk of alloimmunization in sickle cell disease. Sickle cell disease is a chronic inflammatory state. There's immune dysregulation. The chronic hemolysis with the increased free heme and hemoglobin activates macrophages and neutrophils. There's pro-inflammatory cytokine release. There's increased platelets and activated platelets, and possibly even an abnormality in the antigen-presenting CD4 T cell axis. And all of this pro-inflammatory states increase the risk of alloimmunization. So patients who are transfused in a pro-inflammatory state or in a crisis state are actually more likely to be alloimmunized than when they are not in a crisis state. So that is definitely a contributing factor as well. So there are 3 reasons why alloimmunization is increased in sickle cell disease. The one is the mismatch between the antigens in the donors and recipients. The second one is the Rh genetic diversity. And the third one is the chronic inflammatory state with immune dysregulation. The problem with this is delay in finding blood and severe hemolytic transfusion reaction. So what can we do to improve this? The most important thing is to, as Debbie said, at diagnosis, we should do an ABO, an Rh, and Kel blood grouping. We should do extended phenotyping, and ideally we should be giving phenotypically matched blood. Importantly, if your patient has been transfused in the last 3 months and you request a phenotype, it will be altered because some of those red cells are not their own. Some centers advocate for molecular testing at diagnosis. That especially helps with the Rh variants. This is firstly expensive, and secondly, if you're going to genotype your patient, you must genotype your donors, and then we will need 4 times the amount of donors that we currently have. Always judicial use of transfusion, and we really need to increase our African donor pool because that will help us with phenotypically matched donors, and clinically to always think of a delayed hemolytic transfusion reaction if somebody's recently been transfused. Collaboration between clinicians and blood services is very important. We can't give you phenotypically matched blood if we don't know that your patient has sickle cell disease. So ideally, prior to the first time they are transfused, or even if by the time you see your patient, the patient has already been transfused, you need to request that form that Debbie showed you. You need to request an extended phenotype so that we can try and give your patient at all times phenotypically matched blood. And then I can't not mention research. In the South African setting, we currently don't have alloimmunization data of our sickle cell patients. We don't know how many of them have alloantibodies. We don't know to what antigens, and even things like Rh variants in our population. Okay, we don't have a lot of time, so I want to move on to therapeutic monoclonal antibodies and blood transfusion. So a monoclonal antibody is an antibody that's produced in a laboratory. It's monoclonal because it's to a specific target antigen only. And as you're all aware, the use of monoclonal antibodies in recent years has really extended greatly. There have been excellent results in clinical trials, and they have more and more of them are coming into routine clinical practice. So they are used in hematology for patients with myeloma and other hematological malignancies. And the reason why we're talking about them today is because often patients who are on monoclonal therapy are also require transfusion support. And sometimes this monoclonal antibody interacts with our testing in the blood bank. So the first one we're going to talk about is daratumumab or Darzalex, and this is a therapeutic monoclonal antibody that's used in multiple myeloma. So multiple myeloma is a disease of plasma cells. The plasma cells express CD38, so this is an IgG monoclonal antibody, and it's directed against CD38. So the aim is, if you give very high doses of this, it will bind to the tumor cells and remove them via a few mechanisms, such as complement-dependent cytotoxicity and antibody-dependent cellular cytotoxicity. It's currently approved for multiple myeloma in refractory or relapse disease, so patients who've received 3 prior lines of therapy, including immunomodulatory agent and a proteasome inhibitor. The dosing is they give it weekly for 8 weeks, and then every 2 weeks till up to 2 years, and then until and then monthly from month 25 onwards until there's disease progression. So what's important here is that it really is a chronic infusion therapy, and this drug stays in the patient's system for up to 6 months after stopping the treatment. So the reason why we're talking about DARA today is that CD38 is not only expressed on plasma cells, it's also expressed at low levels on red cells. So if you are going to send us a sample in the blood bank from a patient that's on daratumumab or on any anti-CD38 monoclonal antibody, it's going to interfere with some of our tests. It's actually going to interfere with all of our indirect antiglobulin tests or any test that uses our AHG detection. So this slide shows you how an indirect antiglobulin test works. The first line is a negative result. So if you've got, so we have red cells that have minor antigens on them. We take your patient's serum that doesn't have any antibodies in it. We mix them together. We then add our Coombs reagent. Our Coombs, this antibody has got nothing to bind to, so there's no red cell agglutination, and it looks negative. It sits there at the bottom of the tube. The second line shows what a positive indirect antiglobulin test looks like. So you've got red cells that express minor antigens. We mix them with your patient's serum that has antibodies. The antibodies bind to the antigens on the red cell. We then add a Coombs reagent. This binds to the Fc portion of the antibodies that are attached to the red cell, and this causes agglutination of the red cells, and that's a positive IIT. The third line shows what happens with daratumumab. So we've got red cells that express CD38. We've got our patient's serum that contains the DARA. This binds to the CD38 on the red cells, and then we add our Coombs reagent. Our Coombs reagent binds to the Fc portion of the DARA, and then you get a false positive IIT. Okay, so as we've described already, the point of an antibody screen is to detect if your patient sample has any antibodies to red cell antigens. And with daratumumab, it looks like they do because they have a positive antibody screen. It's usually weakly positive. So what we do when we see a positive antibody screen, the next thing we're going to do is an antibody identification with panel cells, like has been discussed. So the problem here again is that if your patient is on DARA and we do an antibody identification, all of the panel cells are going to look positive, about 1 to 2 plus, and it looks like an autoimmune hemolytic anemia, a pan-reactive autoantibody. And then if we'd want to do adsorption studies to remove the antibody, this usually fails because there's not enough CD38 on our cells to remove the DARA. So the biggest problem here is that if your patient is on daratumumab and you don't tell us, we can spend days trying to work up this pan-agglutinin or this warm autoantibody when really it's just a drug effect. And the second problem is that there could also be an underlying alloantibody which we might miss because of the DARA sitting there. So what about ABO and RH with a patient on daratumumab? So the tests that we use are usually IgM. They look like this, like a pentad, and they bind directly to the red cells, so DARA does not interfere with them. So your patient will have a correct ABO and RH, but their DAT could be positive or negative. It's actually usually negative, but the antibody screen and the antibody identification will always be positive. Okay, so if the problem with DARA is because of the CD38 sitting on the red cells, we need to try and remove the CD38 from the red cells to aid our testing. So there are a few different options to alleviate the daratumumab interference. The one is recombinant CD38. So that's just we flood the system with the sample with CD38. It binds to the DARA and removes it from the circulation. Another one is an anti-idiotypic antibody. So this would be where it's an antibody that binds directly to the FAB portion of the daratumumab. That's the portion that binds the CD38, so it blocks it as well. Some studies have tried to look at using cord blood cells because they lack CD38. But really the most useful, user-friendly, freely available and cheapest one is to use DTT. So DTT is a reducing agent. What it does is it breaks disulfide bonds, and CD38 is attached to the red cell via disulfide bonds. So if we could add that, it will break that bond. The CD38 is no longer bound to the red cell, and then we can use those red cells to test your patient sample. The problem with this is that CD38 is not the only antigen that's attached to the red cell via disulfide bonds. There is specifically CAL is a problem and some other antigens. So if a patient has an antibody to any of these antigens, then we won't pick it up if we've already added DTT. So that's a big problem, specifically big K. So there are two options. Ideally, you should phenotype your patients so that if they're big K positive, you know they can't make the antigen, or we need to give all of these patients K negative, big K negative units. I don't need to go into that. I just wanted to show you here. So this is a patient that's on daratumumab. The first three are screen cells, and this is the auto control. And you can see that they all look positive, or funny, strange positive. And then when it was DTT treated, you can see that CD38 was removed and they all become negative. Okay, so actually the best way to prevent all these confusions in blood bank is to inform us at the very beginning. Prior to your patient starting on the drug, we will do a baseline ABO and RH. We'll do an antibody screen. If that's positive, we'll do a baseline antibody identification. We'll do a DAT, and then we'll do extended red cell phenotyping for all clinically significant antibodies. And then once your patient starts the treatment, at least we know what they are at baseline. I don't need to go into this. These are the international guidelines for what blood to provide to patients on DARA. So ideally, we should provide ABO and extended RH and K compatible units after we've used a DTT-treated reagent cells to do both an antibody screen and then if there are antibodies to identify what they are. If it's an emergency and we don't have time for this, and blood is needed urgently, we can provide ABO extended RH and K compatible units pending further serological testing. Overseas, where daratumumab is, many more patients are on daratumumab, what they actually do is give their patients an ID card that they have to carry around from when they start the treatment to 6 months after therapy. And it has their name as well as prior to starting DARA, or the date they started, and then exactly what their ABO and RH blood group is, and if their antibody screen was positive or negative, and if it was positive for what antibodies. So really baseline testing should be standard for all patients on daratumumab. But this is not the only monoclonal treatment that's coming into practice that affects our blood bank. Camellia, hopefully in the future you will not use this drug, is an anti-CD47. It's used in AML and MDS, and it actually acts as a do not eat me signal in healthy tissues. So it's for macrophage-mediated phagocytosis inhibition. So if you block this on CD47 cells, the one big problem is that these patients can get an autoimmune hemolytic anemia, because then these red cells no longer have the sign to say, do not eat me, and they are phagocytosed by the macrophages in the spleen. But the next problem is that it causes an anomalous blood grouping, and we actually can't identify what ABO blood group these patients are on. So these patients have. So ideally, they should have an ABO blood group before. Otherwise, most of these patients end up getting group O red cells. So really the take-home message for therapeutic monoclonal antibody treatment is that serological interference is not going to go away because the use of monoclonals is only increasing. There are definitely other anti-CD38 treatments in the market, and anti-CD47 is another one that's internationally causing a lot of problems. So the most important thing is really to early communication and baseline testing in your patients, because the biggest problem is delay. All these tests cause delay in us being able to supply your patient with blood. Thank you.
Thank you very much, Tanya. We are just in time. So because of the importance of the questions, I do want to go through them, if that is okay with everybody. Can I just have a thumbs up that we can continue for 5 minutes?
Yes, I think everybody wants to know.
Good. Okay, so I think the one very important question is from Tomek. You asking if you have a new patient with sickle cell disease that comes to your clinic, can you just assume that baseline blood testing was done? You know, could obviously be at a facility that the patient was possibly transfused a previous time, and how do we access this information? So this is a very important question. Before I ask the speakers to comment, I think the one thing is to never assume that somebody has had baseline testing in the scenario. We know many of our sickle patients are quite nomadic. They come and go, and you definitely need to check that out. So obviously, the 2 blood transfusion services, if it was done, would be SANBS or the Western Cape. So if baseline testing was done, that information will exist at the blood services. And the best would be is to know who heads up those laboratories. So you met the SANBS people today, but there are our colleagues in Western Province would also be able to help you. But I think the message is never assume, but rather check this out. Okay, the next question, I don't know, maybe Debbie or Nitesh, you can answer. Are the recommendations similar for other hemoglobinopathies, such as thalassemia? Is there baseline testing for other hemoglobinopathies?
So shall I just jump in there, Utam?
Yeah, just go.
So there isn't really any prescribed standard at this stage, but we do feel quite strongly that if you know your patient is going to be transfused over a long period of time, it's a good idea to do some baseline testing and to manage that accordingly.
Okay, thank you very much, Debbie. Then from Andrew McDonald, we would appreciate a comment on red blood cell genotyping versus phenotyping. So maybe I will start off, and then Nitesh, you can take over. So you've heard a little bit about the red blood cell genotyping that we do in SANBS. It is really part of our extended algorithm. And although serological phenotyping is still in a way gold standard, definitely the molecular genotyping is the way it is going. And obviously the vision is here, you can more specifically match donor and patient if you do that genotypically. So I do foresee that genotyping will be used more and more, and it is definitely part of our algorithmic testing. And we are actually collaborating internationally with a group and 9 European countries on getting a red blood cell high throughput analyzer accredited, so that you could type donors genotypically very quickly, and the vision is that will replace phenotyping at some stage. And obviously in South Africa, our population is much more genotypically diverse, and it is very important that we participate in such studies to ensure that our unusual or more rare blood groups are detected as well. Sorry, do you want to comment? Okay, I think that's fine.
Sorry,
Hi,
Ute.
Dr. Utsa.
Sorry, Ute, it's my fault. It jumped around and I muted you inadvertently. Sorry. I can't find you. Sorry.
Okay.
Sorry.
Where did you lose me?
A sentence or two. Sorry, it's my
Okay,
fault.
so
Yeah.
no problem. Okay, so just back and maybe again, Debbie or Nitish, would you want to ask that how do we release the most suitable blood for a patient that's difficult to cross-match?
I think the answer to that question is how much time do we have here today? Because there really isn't an easy answer to that question. Just in a nutshell, we would really ideally want to identify antibody specificities, be that by a straightforward antibody identification or extended testing in the reference laboratory. And then we would, then the second line would be to issue antigen negative blood. But it's not always as simple as that. And it really just depends on what the cross-match looks like and what the problem is. Nitesh can possibly add, but really this is almost a subject on its own.
Yeah, exactly.
Yeah, if I can just add on to what Debbie says there, you know, we would get patients, especially in the reference laboratory, where you'd see the patient has maybe 4 or 5 different antibodies. And in that case, you'll actually have to speak to the patient's treating doctor and try and select the most suitable blood at that point, and then give treatment afterwards to manage any reactions that the patient may have, because it may not always be possible to give antigen negative blood for these patients. We will, of course, really try to provide it to the extent that we would try and get donors' blood and do extended screening. But this is really a subject all on its own.
Thank you, Nitesh. And also with that, just to Kingsley's question, whether, you know, which methods we use. So again, it's a topic for another day, but we use a whole combination of testing methods, including things that you mentioned, like elution, selected cells, auto, absorption techniques. We have manual and automated tests. And then all of that really culminating in molecular testing. So really a complex case will go through a whole spectrum, whole algorithm. And normally the last thing we will do is genotyping or molecular testing as well. So I hope that helps you. So from Larry, I note that chronic inflammation is a factor in immunization. Does HIV and long COVID, are these risk factors? I mean, my gut sense would be yes, HIV is pro-inflammatory. We know, and also long COVID, we know that the immune system plays a role. I don't know if we know yet, well, we know how HIV, what the role that HIV plays in selecting blood for our HIV positive patients. We know they generate autoantibodies and other non-specific antibodies, and that does interfere definitely with testing and cross-matching. For COVID, I can't give you an answer, but maybe anybody in this group would like to respond to that. Okay, no responses. Yes,
I haven't come across anything. So yeah, I mean, it seems nobody else has. Yeah, it hasn't given any trouble. But on this topic, I must actually say that the team from Tygerberg, and this is actually the excellent moment to say it. I don't normally advertise talks, but I will put it on the Sagas WhatsApp group. The team from Tygerberg and Wits is doing a specific talk about, what is the title? It's COVID, 19 hematology, hemostasis, and autoimmunity. So perhaps they have something about that. Ziv, if you're still here, see if you can't answer that question then. So that would actually be a nice talk, and it's on the 10th, but we will post it. Okay.
Thank you, Estelle. Then Tomik wants to know, where can I download the extended phenotyping form? I'm sure you can get a copy from us. You're also welcome to come to our laboratory and see how all of this works. I know Cape Town is a bit far. You just want it out of interest, I guess. Why don't you contact Debbie or Nitesh or Luandri, and then we can assist you with that. And then Andrew's just telling the audience, daratumumab is now registered for frontline unit use in SA, although not in common use because of the cost. Thanks for that comment. And okay, and then the SANBS website has all our contact details for those who want to get in touch with any one of the speakers or myself or Tanya. Good, so we've done very well, a lot of information in just over 1.5 hours. I just want to thank my co-host Estelle. Thank you very much for hosting with me today, and a very big thank you to our speakers, Debbie, Luandri, Nitesh, and Tanya. Thank you very much for your preparations and for educating us this afternoon.
Thank you, Uta. It was a great session, and I really can see why they call you experts. It was very difficult for me. I think I'll have to do this again, but much slower. So thank you. It was really helpful, I hope, to all of us, and great attention from the audience, clearly. Next week, we're going to choose the best TKI for our patients with the Bloom team. So have a great Monday evening. Thank you, everybody.
Thank you.
Thank you.